thank you for supporting our symposium series. This is the third one in this current series that we put into place, with more to come. For those of you who would like to get on our mailing list, out in the foyer when you're leaving, there's a little composition notebook. If you would sign in, some of you did the last time, but if you are not in the book and you would like to be on the mailing list, please sign in or print in, give us a name and an address, and we'll keep you apprised of what's on the agenda. I would like to introduce a former colleague to you. Before her retirement, she chaired the CCM nursing department. She will make the introductions of the guest speaker tonight. This is Professor Emerita. I got my gender right. May Wolf.
Good evening and welcome to the symposium tonight. Tonight's symposium is jointly sponsored by the Student Activities and the College Symposium Committee of the Center of Teaching Excellency. It is dedicated to Dr. Marjorie Gelford, Professor of Psychology, who chaired the college's Symposium Committee and who unfortunately recently died of cancer. Our speaker is Mr. Ralph Nader, consumer advocate, lawyer, and author. His first book, Unsafe at Any Speed, published in 1965, attacked the safety of Chevrolet's Corvair. General Motors was opposed to the author and to his book, but the outcome was that the book sales increased, and Nader, a once obscure Connecticut lawyer, became world famous. Since that time, Mr. Nader and his various consumer agencies have made progress in auto safety, environmental protection, occupational safety, and health administration, consumer product safety, insurance rate rollbacks, safe drinking water, and airbags in cars. Since 1988, Mr. Nader's work continues for government reform, insurance reform on a national level, and greater auto safety regulations. Presently, he is experimenting with consumer-side entrepreneurship and the power of group buying. Also, he speaks on the topics from product liability to food additives and pollution. In recent years, Mr. Nader's consumer groups have launched investigations into the nuclear power industry, the Educational Testing Service, and the United States Postal Service. His recent book, The Big Boys, Power Position in American Business, which was published in 1988, was co-authored with William Taylor. It examines the internal composition and the external power of 9 of America's most influential companies. Mr. Nader graduated magna cum laude from Princeton University's Wilson School of Public and International Affairs in 1955 and Harvard Law School with distinction in 1958. He is an American legend. He not only talks about citizen action, but he lives it. Ralph Nader is one who has made changes, and now it is my privilege to present Mr. Nader. Mr. Nader.
Thank you very much, May Wolf and Richard Siegel. who was here when I was here last 20 years ago. And ladies and gentlemen, the topic this evening is not usually considered a very pleasant one, the American healthcare crisis. And it's important to define really what will be discussed this evening a little better. We tend to use euphemisms when we talk about health and disease in our country. We talk about life insurance instead of death insurance, and health care instead of disease treatment. There are really two separate problems, and they are interrelated. One is what kind of individual and social and national health care policies do we need to refine in advance? And second is how they can be paid for where they cost money. Not all health care policies cost money. If you stop smoking, you save money. If you stop drinking, you save money. If the auto companies put airbags in cars, as they're finally, shall we say, being induced to do, you save money as a society, and you save money on your auto insurance, far more than what the additional amortized cost of the airbag would cost you. I want to start with the issue of health care before we talk about the problem with health insurance, which is disintegrating now at a dizzying pace, as we all know from many of our own experiences and what we read in the newspaper and watch on television. The first emphasis of any health care should be prevention. Now, that's often repeated, and then people go on to other things. We've made great progress compared to what we thought would happen in cigarette smoking, for instance. 400,000 people die in the United States every year due to tobacco-related diseases, lung cancer, heart disease, etc. Those figures come from the Surgeon General's office of the Department of Health and Human Services. Actually, the latest estimate was 420,000. The latest estimate for passive smoking deaths is now over 40,000. Over 40,000 people a year die because they grew up or they worked in an area where people were smoking constantly and they were inhaling that smoke. So we now have passive smoking casualties almost equivalent to the number of people who die on the highways in the United States. Now, in 1964, when the first Surgeon General's report came out on smoking and health, about 42% of the American adults smoked. It's now down to 29% and dropping. In California, it's 22% and dropping. Recently in California, voters voted an initiative into law putting a surcharge on the tobacco sales, a good many of which dollars are used now for education, to encourage young people not to start the habit, and for television ads. And the television ads are really very, very clever. You know, once you get these Madison Avenue copywriters doing something constructive for once, they can become very, very clever. In fact, the most effective anti-smoking ad I ever saw, which never made it on TV, was one with two color slides. One was a color picture of a diseased lung of a smoker. And then the second slide came on with the words, "That's Marlboro country." Now, what we've seen is that a lot of public information, a lot of renewed initiatives by physicians with their patients, a lot of movement by non-smokers for eliminating smoking on airplanes, having non-smoking sections in public buildings and restaurants. A lot of disclosure that has disgusted people about the tobacco industry's cover-up through litigation. Those lawsuits, the Cipollone case here in New Jersey, which launched it, kept the issue alive, kept reminding more and more people. A lot of youngsters nagging their parents, having seen anti-smoking material, nagging their parents to stop smoking. These are all coming together, and I think that we're beginning to see the end, the beginning of the end, of the smoking epidemic in this country, probably over the next 30 years, it could well be down under 10%. It is now socially unacceptable to smoke. When I was an undergraduate at Princeton, it was unacceptable not to smoke socially. You fell out of it. Students blew smoke in your face if you didn't smoke. You walked into a classroom, you could hardly see the teacher because of the smoke. And now it's completely different. And it's the social stigma that actually is being very, very effective. It's now increasingly considered unclean, soiled, bad cosmetically, etc. So this tells us a lot about how to get something done. It tells us, first of all, you can't deal with an addiction very well at all by prohibition, legal prohibition. We learned that when we had a constitutional amendment right after World War II, which prohibited, World War I, which prohibited the sale of alcohol. The prohibition movement. It was a political party, actually. This is for those of you in the audience who are young and can hardly remember the existence of World War II. What happened was that the alcohol industry is driven underground, moonshine stills, all kinds of crime, and we're still inheriting that criminal legacy to this day. And it didn't work, and the amendment was repealed. And so the same happened, is happening now with street drugs. Much as we despise and dislike and loathe the utilization of heroin and crack cocaine, etc., we are spending between $8 and $12 billion a year, trying to interdict suppliers of hard drugs, both domestic and coming from abroad. And after 10 years of this, more supply is coming in than ever before, and there is very little progress in terms of cutting down the availability. The only progress is from the point of view of the street dealers, because now it's very cheap and they've got a bigger market, such as crack cocaines. Now, do you know how much our government spends to discourage people from smoking, or young people from smoking? About $2.5 million. That's about the budget. We spend almost $100 million subsidizing the price of tobacco, and about $2.5 million in a little office in HHS trying to do something about the younger generation's coming addiction to tobacco. But $8 to $12 billion in a futile effort to deal with hard drug supply. Hard drugs take 8,000 lives about a year. That compares with tobacco, over 400,000 lives. So you can see our priorities are certainly open to question, and our smarts are open to question. Time and time again we're told, you want to do anything about hard drugs? Deal with the demand. Why is it that most youngsters don't take drugs? If you answer that question, you will understand more about why other youngsters do take drugs. Maybe it's because they're not wanted, they're not needed. They don't have anything useful to do. Maybe it's a lot of other things too that have very little to do with our usual policies toward the drug problem. It could be also that in the area of alcohol, which takes over 110,000 lives a year, we are pursuing inadequate policies. Studies have shown that alcohol tends to decrease in consumption, along with tobacco, if it's taxed more heavily. In Canada, a pack of cigarettes cost about $4.50 American dollars. That's how high the tax is. The studies have shown, particularly for younger smokers, the higher the price, the less they smoke. The same is true for alcohol. It turns out that alcohol and tobacco's taxes haven't even kept up with inflation since 1950. That is, in real dollars, the revenues we're getting from alcohol and tobacco have been declining. So it's not even keeping up. Secondly, we still haven't faced up to the problems sufficiently of tobacco advertising. We have now in inner cities these most elaborate billboards and free samples trying to hook the inner city youth into a lifetime of tobacco addiction. We have the tobacco companies writing memos within their companies saying, you know, we got to do something about replenishing our customer base. They're losing 5,000 customers a day, the tobacco industry. 4,000 quit, 1,000, a little more, die. They have to find the substitutes. And the substitutes are rosy-cheeked youngsters, male and female, who are in junior high school or high school. And they are trying every conceivable way that isn't too overt to do it, like Joe Camel. Joe Camel was a spectacular promotional success, and it was directly targeted for younger smokers or smokers-to-be at that age. The tobacco industry is going overseas now, using the State Department and our tax dollars to promote sales and break down regulations against tobacco advertising so that our tobacco exports can get into these countries, such as in Thailand. Thailand sent an official objection to our government to the collaborative effort by the State Department and the tobacco industry to destroy their emerging and growing restrictions on tobacco advertising. Even Japan fell before this onslaught. So one area where we've gained on Japan. Japan used to exclude U.S. tobacco. They put a heavy tariff on it. And the U.S. in effect went to Japan, the U.S. government under Reagan, and in effect admitted, well, they couldn't sell them anything that they wanted in terms of consumer products. Get rid of the tariff so we can sell you cancer by the stick. And it worked. We now have about 18% of the Japanese tobacco market. The rest is a government-owned tobacco company. In Japan, 60% of adults smoke. Until 4 years ago, it was considered a way to increase your efficiency and concentration at work. The government had a stake in tobacco sales. It took in $14 billion equivalent in tobacco revenues, and it was not about to allow its health department until very recently to tell the truth to Japanese citizens. So you can see that the endless little work, the talk shows, the pamphlets, the doctors' advisories, the non-smoker movement, this is how things get done in public health. It's very rare that we have the instant vaccine anymore. We eradicated some of the major diseases through vaccination, smallpox and typhus and typhoid, and by public sanitation. But for the area of addiction, which is the big killer now, it has to take a much more sophisticated approach, a much more incremental approach that involves all of us. I don't know how many of you have seen recently a friend or relative die from lung cancer due to smoking. How many? Can I see the hands? You ever see a more appalling, painful sight? Probably second only to asbestos-induced mesothelioma, stomach cancer, where 200-pound men end up 80 pounds before they die. So I have a friend, for example, who I grew up with. We played sports together. He started smoking at age 20. And when he became 50, we used to exchange birthday gifts. And I said, look, I'll give you a completely paid stop smoking clinic ticket. You can go to one of these smoke enders. And he wrote back and he said he didn't appreciate my offer, and he was not amused by my urging him to stop smoking. That's how badly addicted he is. And he's still smoking. It's a very sad thing to see. At any rate, a lot of our consumer work focuses on the prevention of violence, and it's not the way we view violence. When you hear the word violence, you think of street crime or wars. The violence we try to prevent is the silent, cumulative, often invisible violence that we too charitably call pollution, toxic chemicals in the workplace, addictions, etc. And to give you an idea of what it costs, last year we spent $731 billion on health care, and 10% of that was due to tobacco-related diseases. Over $70 billion, right there. This year we're going to estimated to be spending as a nation $825 billion. And according to the U.S. government statistics, by the year 1997, we will be up to $1.47 trillion for health care. Now, our entire economy last year was $5.7 trillion. So by 1997, 1 out of every $5, assuming a certain amount of growth in the GMP, 1 out of every $5 could be going to health care. It's already 14%. Japan spends 6.5% of its GNP, Canada 9%, Sweden spends about 10, 11%, and everybody is covered in those countries. Everybody, from cradle through nursing home. In our country, we spent 14%, probably just under 40 million have no health insurance coverage. Another 40 million are grossly underinsured. They have policies, but there are a lot of things they leave out. And the rest of us are beginning to wonder what full coverage means anymore. If you move from your job to another job and you have asthma, the group policy of the new job will say to you, we'll cover you, but not your asthma. That's called a pre-existing condition. It has now been raised to levels of absurdity that defy caricature. I have a friend in California. He's married. They're both about 40 years old, 2 small children. One child injured a knee a year ago. Another child had a respiratory problem. And his wife had another medical problem. And he had a problem with he had a fibrillation problem. Nothing serious, but he had to go to the hospital, and they said it's okay, nothing serious. He was paying $10,000 for family policy. He wanted to switch. He thought it was a little high. He was offered a similar policy coverage by Blue Cross for $6,000, except Blue Cross said, we won't cover anything dealing with your heart for 5 years, and as far as your wife's concerned, we won't cover that problem. And your child's knee, we won't cover that problem for 5 years. I mean, you know, you go up to Canada and you tell them these stories. They cannot believe it. There are books being sold in the U.S. that show older people how they can impoverish themselves so they can qualify for Medicaid before they're going into a nursing home. And they say, well, shift the assets to your spouse or your children, or as a last resort, divorce. And then the final resort is go to Mexico because they got cheap nursing homes there. And you show these books to people in Canada, and they can't believe that this is the USA. And the stories keep on, and they keep on. $5,000 a day in 1986 for intensive care in a San Diego hospital. No operations. They were charging $7.50 for a Bic razor. Everything was built into the overhead. You take a pill, it's $6. You make a move. You rub across the carpet, they almost charge you. Now, we have this situation where we're told by organized medicine, even though a lot of doctors know the contrary, we're the best in the world. They keep telling us, you know, we're the best in the world, to keep us complacent. Well, as they keep telling us we're the best in the world, let's look at the figures. We do not have the longest life expectancy of any country in the world. In fact, we're about 8th. Japan is first. Infant mortality, 22 countries have lower infant mortality than we do. And try this for a comparison for anybody who even gives the time of day to people who keep bragging about us without any factual basis. Washington, D.C. has infant mortality double that of the nation as a whole and higher than Jamaica or Bulgaria. It's a disgrace. And this is an area that has one of the highest average incomes in the United States. It has a 58% inoculation level for infants, immunizing them against childhood diseases. This is after a crash program a few weeks ago. That's lower than the inoculation rate achievement in the country of Botswana in Africa. Measles is coming back. Tuberculosis is coming back in a more virulent form. And of course there's AIDS. And we have about the highest level of AIDS deaths now per capita in the world. There'll be other countries catching up to us, apart from Africa, that is. There'll be other countries catching up to us. But we're ahead of any country in Western Europe in per capita, 200,000 deaths since 1980. You look at some of the success stories, they never get publicized. There are 600 community health centers in the United States set up under Lyndon Johnson, the War on Poverty. They are funded by $600 million by the federal government, and they get another $800 million from various sources, private insurance, the patients paying some, etc. They serve about 6 million people. The doctors are employees of the health center, so are the nurses, and their interest is in getting people well. They don't get extra money if they have phantom operations or duplicative operations or prescription drugs that shouldn't be prescribed. You know how little $600 million is today in Washington? I'm sure you know, but I want to rub it in. When George Bush announced that the B-2 bomber was no longer going to be purchased up to a level of 70, because the B-2 bomber had two things going for it. One, it was designed specifically to counteract the Soviet Union threat. No more Soviet Union. They don't have to worry about Moldova and Lithuania, Ukraine. Second, it was supposed to be a stealth bomber to evade radar. Turns out it has technical difficulties, one of which is it doesn't evade all kinds of radar. So George Bush said, we're not going to build 70, but for old time's sake, he's going to buy 20. $1 billion apiece. Compare, one B-2 bomber is $400 million more than the entire federal outlay for this quite successful delivery system through community health centers around the country. In terms of group health, Puget Sound in Washington State, around Seattle, we've had our doctors go up and visit it and look at it. Remarkably well organized, much more efficient by comparison with other HMOs, and a very good monitoring system to make sure if things go wrong, if things are not pursuant to the plan, they correct themselves. This was set up many, many years ago. It was one of the first group health plans. You know, there was no group health. There was no prepaid medicine until the 1930s. The first prepaid health institution was in Elk City, Oklahoma, by a doctor who got tired of going to one farm after another and was unable to serve the farmers and the farm families, unable to give them proper surgical treatments because they had no money to pay. So he started a hospital which was owned by the farmers. And for $38 a year, it's quaint, they got hospital services, except for food and anesthesiology. $38 per family. And this hospital ran for 15, 20 years, but it was the first one under attack by organized medicine. They tried to run this doctor out of the state, out of the county, take his license away, strip him of his malpractice insurance, intimidate younger doctors who were coming to the hospital to work. He took them on. He took them on in the legislature. He took them on in the courts. And it took him until 1948 before he won. But that example and his travels all over the country stimulated the emergence of prepaid group plans going into the Kaiser Permanente, Puget Sound, etc. But as one doctor once told me, he said, any system devised to regulate doctors can design around. not only doctors, the HMOs themselves now, which were originally designed to be more patient-controlled, consumer-controlled, are now moving faster and faster into the for-profit from the non-profit mold, more under the control of health insurance companies, and more under the control of what are known as the providers. And now more than a few of them are starting to go bankrupt, and more than a few of the Blue Cross plans are in serious trouble. West Virginia has gone bankrupt. The giant Empire Blue Cross system in New York says that it has only enough money left in its reserves to last until December of this year, and something's going to have to be done afterwards. Maybe it's slightly exaggerating, maybe it's sometime in the middle of next year. This is a huge plan with millions of people dependent on it for reimbursement. Now, if you ask yourself, are there bright spots? Yes. Are there dedicated physicians and nurses? Some of the most dedicated people you'll see in the world. Are there charlatans? Are there greed-addicted members of the doctor-nurse profession? Of course. But more and more doctors are saying that they can't practice medicine anymore because there's too much bookkeeping, too much paperwork, too much external interference in the name of cost containment. Good motive, but what happens when your grandmother goes to a hospital in Waterbury, Connecticut for a gallbladder operation, and she's turned out in 2.5 days because that is the regime, that is the arbitrary standard for that kind of operation. You say, well, that's supposed to cut down costs, but when it affects you or your relative, you have other priorities in mind. Now, overall, we have to get over this one hurdle. I once wrote an article, a short article on health care problems and insurance. I sent it to a classmate of mine from law school. He works for an insurance company in New England. He was injured in an auto crash, and he's a paraplegic. But he goes to work every day for years. Very smart, very bright, upbeat. And he's had enormous medical bills. And he has a great insurance policy. No matter what he needs, this insurance policy covers. He gets a copy of this article, and he writes me a letter saying, your criticism is uncalled for. And then he gave his own experience about, look at the wonderful coverage he got, look at the wonderful surgery, the wonderful treatment, etc. It's all paid for. Well, I suppose we all can be forgiven for extrapolating from our personal experience, for good or ill. But let's not assume that because some people have access to very good medical treatment and have full insurance coverage, that the system as a whole can be considered anything other than a terrific deal. For a lot of people, it's more than just money and prices. For a lot of people, it's more than just availability, accessibility, affordability of doctors. For many people, it's being caught in a whirlwind of unnecessary procedures, unnecessary operations, all kinds of duplications, phony and fraudulent billing. And let me give you some examples. This is a report from the General Accounting Office in Washington. This is the investigative arm of the U.S. Congress. There are 5,000 accountants, and they just love to investigate and do numbers. They have no partisan political agenda. In the old days, they would have worn green eye shades. This report is called Vulnerable Payers Lose Billions to Fraud and Abuse in Health Insurance. You turn to the summary page, and it said, we found that vulnerabilities within the health insurance system allow unscrupulous health care providers, including practitioners and medical equipment suppliers, to cheat health insurance companies and programs out of billions of dollars annually. Estimates vary widely on the losses resulting from fraud and abuse, but the most common is 10%, or $70 billion this fiscal year. And we talk about bank robbers? You know what bank robbers got last year? $36 million. Million. They're in the wrong business. And then they go on to say this diverts scarce resources and contributes unnecessarily to the health care cost spiral. This is polite language for sabotage of the health care system. And then you turn the page. Haven't you ever heard of GAO reports? Look, can I see the hands if anybody's heard? They're really great. You can get them free. It's one of the last things you don't have to pay twice for as a taxpayer. You've already paid to produce it, and they don't charge you again. You know the North American trade agreement, which you read about? You've already paid Bush and his trade negotiators to cut that terrible deal. And now they got this trade agreement, which is 1,150 pages plus tariff listings. And you know what they say to you, folks? If you want to know what this is going to do to the future of your jobs, environment, and consumer safety, it's $120 at the local Kinko retail store in Washington, D.C. They even subcontracted it out to Kinko's. Of course, very few people are lining up. And that's the whole point, that they don't want us to know what's in this trade agreement before the deadline for Congress to vote it up or down on May 1st is. Now, this you can get free. These you can get the index, you can get on their monthly publication list, so you can check it out, and they cover all kinds of areas. Defense, housing, health care. It's shocking that the total distribution of these reports, and they come out with maybe 700 a year, to the United States of America and beyond, is less in terms of copies than the latest edition of the saga of Morris the cat, or Garfield the cat, to be more precise. Excuse me for the feline error. And you turn to the inner page, and they give you an example of what they're talking about. And overcharging, billing for services not rendered, rendering inappropriate or unnecessary services. For instance, in California, they caught one operation that stole $1 billion. They used cellular phones, they had forgeries, they had phony practitioners, etc. Now you say to yourself, $1 billion, why didn't they catch them when they reached 100 million? Well, that's what deregulation is all about, folks. It's taking the federal cop off the health care fraud, waste, abuse beat, just like they took the federal cop off the savings and loan beat. And look what the savings and loans, 1,000 out of 3,000 of them, are doing to us and our children for a $500 billion bailout, at least over the next 30 years. Now, when you look at the overall part of this here, you have $800 billion, take a few here and there, $800 billion bill a year for health care. 70 to 100 billion is waste, fraud, and abuse. They always take the most conservative figure. Another 130 billion, based on studies that have been made in reputable medical journals, etc., are clearly beyond any discretion, totally useless or duplicative medical services. Another 70 to 100 billion is paperwork that could be avoided if we had more streamlined payors, or a single payor, the way Canada does, where you have your free choice of doctor and hospital, but the province is a single payor. No cross-billing, bookkeeping, fighting, squabbling, paperwork, etc. Healthcare administrators are increasing faster than any other category in the healthcare industry, far more than nurse practitioners or doctors. You're already up to about $270 billion of the $800 billion bill. And there's more. In 1970, 5.5% of births were by cesarean section. It's up to 25% now. Doctors and hospitals make more money from cesarean section. As one reason, at least half of those cesarean sections are totally unnecessary and border on criminal negligence. You see hospitals in the same area in Maryland, some with 10% rates, 15% rates, and 34% rates. You see hospitals a few miles apart charging, one charges 3 times more for an identical operation as the other. When I showed New York City physicians that $5,000 a day intensive care bill in San Diego in 1986, and they looked over all the details and the medical records of the patient, they said that in New York City, that would have been $1,800 to $2,000. In Dayton, Ohio, an appendectomy, for example, is less than half of what it is in an eastern town. In Connecticut, a 60-year-old woman, good health, independent Blue Cross Blue Shield policy, pays double what a similar woman is paying in Boston. Same age, same health. Blue Cross Boston. If anything, Boston prices are higher than the prices in a Hartford suburb. And yet, why? One reason is differential management expenses. Blue Cross have been living high on the hog, huge government, huge corporate salaries. They buy boxes at baseball and football stadiums. They buy Olympic tickets, tens of thousands of dollars. Maryland Blue Cross bought. So there's a differential in the way they are managed, but that doesn't account for all of it. There is a gross irrationality here. It's like they price on arbitrary levels that cannot be explained by, well, New York City is a little more expensive than Newburgh, New York, sure. But even when you take those differentials into account, you can't account for that kind of gap. With that kind of waste, how can the health insurance system fulfill its 5 critical objectives? Reimbursement, universal coverage. Don't we really need that in this country? We're the only industrial society in the world, Western world, that does not have universal health insurance coverage. South Africa doesn't, we do not. All the others do. The second function is quality control. The third is cost control. The fourth is preventive medicine, non-smoking clinics, spreading the idea of exercise, good diet, good nutrition. Diet-related diseases were considered minuscule 50 years ago. And now, every year, the connection between diet, high fat, low fiber, high sugar, high salt, and others are being documented. Even better, there is now much better research than ever before connecting certain kinds of foods with reducing the risk of cancer, for example, beta-carotene in carrots and some other vegetables. It's no longer just, well, I saw it on a talk show. It's increasingly documented with controlled studies. High fiber, reducing the risk of colon cancer. In addition to quality control, cost control, preventive medicine, universal coverage, we have the need for consumer organization. Congress now has dozens of bills for health insurance reform. The pay or play, you've heard about that. George Bush has a plan. Senator Mitchell has a plan, along with Senator Kennedy. Senator Wellstone has another plan. Congressman Conyers has another plan. Congressman Russo has a plan. The AMA has a plan. The AFL-CIO has a plan. There's no better way to make sure nothing happens than to have so many plans up there that nobody around outside in America knows what to support. And some of them overlap, and they all have wonderful sounding names. Wonderful sounding names. But they all fall into three categories. One is the pay or play, which is to force insurers that don't, employers that don't give you coverage to either give you coverage or to put money into a fund that will provide you with coverage. Another is basically tinkering with the status quo. It tries to deal with tax credits and so on and so forth. It doesn't do anything about the cost spiral or quality control. And the third is a variant, and there are some wide variants on the version that we have in Canada, we see in Canada, the single payor. The single payor plan in Canada, as I said, covers everyone from nursing home all the way to the cradle. And it does so on 9% of their economy compared with 14% that we spend in our country. They have a higher health expectancy in Canada than the United States, lower infant mortality, longer life expectancy. They have their problems, but their health care is at least as good as ours overall. They certainly don't have the huge gaps that we do. You don't see the massive type of situations that you see in some of our cities, the Medicare mills and the crassest type of charlatans bleeding people out of their last funds for quackery medicine. You have a much better database with a single payer system because you don't have 1,500 insurance companies with advertising, promotion, marketing, cross-billing, etc., cost shifting, and they don't share the data. So you'll be able to see trends in health care, occupational diseases, much more effectively for preventive action under a single payer system. In Canada, they have their own choice of doctor and hospital. And if you ask Canadians, what is the one thing they'll fight to the end for as they're being absorbed into a North American common market? It's that little card that gets them health care. A Canadian political leader came to the United States once to give a speech on health care, and she went through some of the horror stories her American friends were telling her about. And she said she had a back operation, she had rehabilitation, she had prescription drugs, and she never saw a bill. And one American stood up in the audience and said, "But in Canada, what do you do for terminal patients?" And she said she was stunned by the question. It's as if the person was expecting her to say, "We shoot them." You know, what do you do to terminal patients? They take care of them. It's said, of course, that there are long waiting periods in Canada. This really upsets Canadians. For emergency care, no. For elective surgery, like here. I was just in Berkeley, California, they're waiting a month for a mammogram. They wait 8 hours in many emergency hospitals in the cities in our country, according to the studies. Emergency rooms, they're waiting. I lost a friend who died from heart attack because he was rushed to his hospital by his wife in Washington, D.C., 4 blocks from the White House, and they made him wait for 4.5 hours, and he died. And where is the longest wait? It's when you don't have enough money to pay for anything. That's the longest wait of all. And that doesn't occur in Canada. Now, they have problems. They're getting cost increases, etc. But their problems are very modest in terms of delivery of health care compared to ours. People say, well, Canadian doctors are coming to the United States. Well, the ones who want to make a ton of money will. You know, if they want to make $400,000 as an anesthesiologist in Southern California instead of $130,000 in Vancouver, some of them will come south. But as they're coming south, there are going to be more and more Americans going north to live in Canada because they're covered and won't have to go through the fiscal, financial, and other anxiety, worry, and terror of thinking they can lose their life savings, or they can't get adequate medical care, or they'll be cruelly preyed upon by the fleecers in the system. Let's look at the Medigap policies, which maybe now are about to be reformed somewhat under a 1990 law that passed through Congress. The appeal to fear and anxiety, and the sense that you may lose all that you saved. We get letters from people who've worked all their lives. They got $160,000, $200,000 nest egg. They're saying that one of them cannot be cared for at home. She has to go to a nursing home. He has to go to a nursing home. $35,000 a year. And it'll be gone. It'll be gone in 2 or 3 years, because there are other expenses too to live on, if not $160,000. And they're saying, what can we do? And what are we left with? We're saying, well, here are 5 books. They'll show you how to become a pauper. Maybe you could divorce your wife. Just pro forma. Split the assets. Go to Mexico. Shame on us. While the drug companies are making record profits, the doctors have never made more money than they're making now. The hospitals are raking it in, not very well managed, some of them, so they're not showing much profit. But it isn't because they're undercharging people. And billing fraud alone has reached grotesque proportions, where you get a big printout now. We have a bills project, so we get people sending us bills all over the country. It's amazing what's going on, where they unbundle the charges. They would be charging $1,500 for an operation. Then some consulting firm comes said, why don't you unbundle them and start charging all kinds of sub-charges that'll add up to $5,000, $6,000. That's called unbundling. That's where you get a $7 charge for a Bic razor, among a list of 200 other items. We've seen bills where there are duplicative charges in categories as large as $13,000. At page 1, $13,000, page 4, $13,000, it's exactly the same item. Charges for doctors who never showed up that day. Phantom charges. One woman, in fact, rented a TV set for her hospital room, and they charged her for the rental, and then they billed her for billing her. They charged her $2 for billing her. I mean, it's grotesque what's going on. Did you see Mickey, what's his name, Andy Rooney the other day on 60 Minutes with his bill? I mean, it's all right. Now, let's get to malpractice. You're going to hear constantly, if there's going to be health insurance reform and on Capitol Hill, there's going to be medical malpractice reform. What do they mean by that? They mean to make it even more difficult for people who are subjected to medical malpractice to have an adequate compensation and their day in court. That's all they mean. It's all in that direction. Now, the extent of malpractice is best described by doctors themselves in private conversations. They will tell you stories that even your wildest horrors would not have conjured up, because they're there. They've seen their colleagues. They've been muzzled from going after their colleagues. The discipline of the peer review is not what it should be, and the medical licensing review boards are largely a disgrace in state after state. Most of their penalties go to doctors who are caught cheating financially rather than malpractice. You have several kinds of malpractice. One category is that there are about 5 to 10% of the physicians in this country who are physically incapable of practicing medicine, either because they are too advanced in years, or they are drug addicts or chronic alcoholics. Now, that's a lot of patients. When you consider there are 500,000 practicing physicians, 5 to 10% is a lot of doctors, and they deal with millions of patients. And they often make serious mistakes because they are not in proper shape to practice medicine. A second category can be considered the slip of the knife of a competent physician. This is where you have competent physicians who have to make thousands of difficult decisions a year, and once in a while, they make a mistake. And when they do make a mistake, and someone dies, or someone is given a very serious adverse effect, who should pay? The innocent patient or the doctor's insurance company? Even though the doctor may be a wonderfully competent doctor, for the most part. The insurance company. The third category is what might be called systemic malpractice by doctors who are quasi-charlatans. These are doctors who will perform an operation to get the fee, even though it doesn't need an operation. These are doctors who engage in phantom surgery. They will have someone else do the surgery, and they will bill as if they did it. They'll have an assistant do it. These are doctors who engage in automatic hysterectomies or too easy cesarean sections or carotid surgery, etc. There are categories documented in New England Journal of Medicine and others showing 14%, 16%, 25% of these operations should never have been conducted. There are doctors who look at women who have problems and say, you have psychological problems, and they prescribe drugs. They look at a man with the same physical symptom, and they say, you've got a serious physical problem. Valium is not right for you. 2/3 of all tranquilizer prescriptions are given to women. So you have more of these systemic types of gross malpractices that occur, and then they go out of fashion. For example, you see comparative data from France, Germany, and the U.S. In France, there's a certain class of operations that's much more frequent than the U.S., no other variable to explain it. And then there are some classes of operations that are much less frequent in the U.S., no other variables to explain it. It just becomes a tradition. It becomes a, shall we say, even a fad for this kind of surgery. Have you ever talked to a neurologist about ear, nose, and throat surgeons? I mean, I have never seen such contempt between one doctor against another. And I say, where's the contempt from? He said, well, these guys, they always want to cut. The minute they see a problem, they want to take out the knife. I say, doctor, you're a neurologist. Why should you be talking this way? He said, I got even more to tell you, he said. Sit down. And they go through it. Suppose you're caught in the middle between these two doctors. Let's say you have a neurological problem. You go to the neurology specialist, and various suggestions are made, and prescriptions, and so on. You go to the ear, eye, and throat doctor, ear, nose, and throat doctor, excuse me, and they say, well, I think we should operate. What do? Well, a lot of people will almost throw the dice. If they like the doctor's personality, they've known the doctor, they'll go to Dr. B and not Dr. A. Directly contradictory recommendations. How many people die from malpractice in the United States of America? Medical? The best study available, and there have been about 6 of them in the last 20 years, came out of the Harvard School of Public Health, done at the bequest of the New York Department of Health for New York hospitals. That is urban, rural, and suburban hospitals. The year chosen for the data was 1985. And here was their conclusion, that almost 8,000 people in New York State died from medical malpractice in those hospitals in that year, and many, many more injured. And that didn't include other medical treatments outside these hospitals, or other, say, bad prescription of drugs, etc., that ended up in people dying. You know how many 8,000 fatalities are? It's more than double the number of people killed on the highways and streets in New York State that year. Extrapolated nationwide, it's about 80,000 people. And those were considered very conservative estimates by the Harvard researchers. Plus, of course, hundreds of thousands of injuries. Now, when the doctors complain about the medical malpractice litigation explosion, what are they really complaining about when you question them? One is their anxiety when they're operating, thinking they're going to be sued. It's a natural inclination. The second is the high malpractice premiums they're paying the insurance companies. That seems to be in the foremost of their minds. 25 years ago, they used to have malpractice insurance for 3 categories of doctors. Now it's 14. Why? The insurance companies have learned that if they can have more categories with fewer doctors in each category, they can jack the price up very high on some categories, like OBGYNs, neurosurgeons. And they say, well, it's because they're higher risk. The lawsuits are bigger in those areas. Damages are more extensive. But if you take the insurance principle of spreading the risk, and if you only sock it to the doctors who have an acknowledged record of negligence, so they pay more, you can reduce the average premium to $9,000 per doctor, which is less than half what they pay a receptionist. And right now there are doctors in New York City, New Jersey, and Florida in specialty areas paying $30,000, $40,000, $50,000, $60,000, $70,000 a year because of the specialties, because they break it up into more and more categories with fewer and fewer doctors. Case study in Massachusetts, one neurosurgeon represented over a period of years 24% of the paid serious claims against neurosurgeons in Massachusetts. He paid the same premium as other neurosurgeons who have been practicing 30 to 40 years without a claim, because the insurance companies do not engage in what is called loss experience rating, penalizing the bad doctors instead of spreading it and making the good doctors pay as much as the bad doctors. How much is paid out a year in medical malpractice? This one surprises everybody, even doctors who complain the most. About $2 to $2.5 billion a year. That is less than what we spend in this country on cat food. It's less than half of Ford Motor Company's post-tax profit in 1987, and it's less than what Congress spent on itself last year. How many people get anything by way of malpractice verdict or settlement? From $1 to $1 million? 20,000 in 1988. Just 20,000. Out of every 20 malpractice cases, 1 probably collects anything. Most of them don't even think of suing. Some of them don't even know they've been victims of malpractice. Many of them wouldn't think of going through the tragedy in a courtroom, cross-examination, or suing their family doctor or what have you. Many lawyers won't even take the case. 1 out of 20. So what we're seeing here is again, the inverse priority. There is a medical malpractice crisis. The crisis is in the extent of medical malpractice, the depth of it, and its lack of correctability by the medical profession itself, which is not cracking down on the bad apples. 3% of the doctors account for over 35% of the malpractice in any given state. There is a high degree of recidivism here that operates. They should be able to locate and discipline or strip the licenses from these repeat offenders. The quality of health care extends into the prescription drugs. How many of you have seen this book, Worst Pills, Best Pills? We put it out 4 years ago, our health research group. It had about 200 widely prescribed drugs for older adults. A little over 100 of them shouldn't have been prescribed because they had serious side effects, and their good effects were able to be achieved by the other drugs. So if you have high blood pressure, you have a choice of 6 drugs that could be prescribed. You take the ones that do the job without harming you on the side seriously. Gastrointestinal bleeding, etc. And here we had the FDA, we had the doctors, the learned medical associations, etc., and these drugs were going through from the drug companies, the salespeople, to the doctors, to the drugstores. Billions of dollars a year being sold. The Wall Street Journal had a series of articles recently about some of the horrible hospitals that abound in this land. They're very good hospitals. There's some very bad ones. Again, very little self-correcting mechanism. What all this tells us is that there are 4 obstacles to health care insurance reform: the medical lobby, the hospital lobby, the health insurance lobby, and the doctor lobby, and the drug company lobby. When Clinton and Bush say we're going to change the system, they're whistling in the wind. Unless they can develop the consumer and citizen power that will overcome the intransigence of these 4 lobbies. Now, they're not all uniform. There are thousands of doctors that want a Canadian-type system. There are tens of thousands that don't, but there are thousands of doctors that want a Canadian-type system. Bush is accusing reformers of wanting socialized medicine, including Clinton. Socialized medicine is when the doctors work as employees of the government or a government agency. The only place I know where there's socialized medicine in America is where Bush goes when he's sick. It's Walter Reed Army Hospital and Bethesda Naval Hospital. And it's really amazing to watch these politicians in Congress and Quayle and Bush attack at attempts to change the system as socialized medicine when everything they're cared for is from a socialized medicine. The prescription drugs, the surgery, the bed care, the diagnosis, all comes from the socialized medical unit known as military medicine. They don't seem to have ideological problems with that when they're wheeled into the operating room, compliments of the U.S. taxpayer. Well, that isn't the system we're recommending. We're recommending an improvement on the Canadian single payer, where you take what we're now paying in terms of premiums, etc., and you save over $100 billion of paperwork, which will cover the people now who are not insured, and you focus on the kind of consumer power that will ensure a much higher level of cost control, quality control, and preventive medicine. How do you get the consumer power? This is what's missing in every one of these proposals on Capitol Hill. This is how you get it. Little envelope that you require the Social Security Administration to put when they send the check. You require the HMOs and the health insurance companies when they send you a bill or other notice in an envelope. Little envelope, it opens up into a letter which says, "Dear consumer of health services, you may be concerned about the plight of health care and health insurance in the United States and want to do something about it. If you are, finish reading this letter, which shows how you can join a statewide consumer health reform group with a full-time staff accountable to you based on voluntary dues of $5 or more a year." Every state would have thousands of people belonging. There would be about 8 to 10 million who would join up within the first year based on our experience with a similar group in the utility area in Illinois, where they got the insert by state law in their utility bill in the early 80s, and they opened up their bill, electric, telephone, gas, and they said, "Oh, look at the bill this year, month," and out fell this little envelope. It said, "Are you fed up with your high utility bills? This is not printed by your utility company." And they said, "If you are, you can join the Illinois Utility Consumers Group." 200,000 did. That group today, with their full-time staff of economists, health specialists, attorneys, have saved Illinois consumers over $3 billion in utility rate increases. Plus, representing Illinois consumers for the regulatory agencies, the legislature, the court, and at news conferences to present a collective intelligence representing consumer interests on many areas from telecommunications to electricity and natural gas. The same thing can happen here. We need easy instruments by which we can join together and band together and be an intelligent force for reshaping the health insurance system and the health care system from prevention to diagnosis, to treatment, to rehabilitation. And this is the way to do it. When people are at their peak point of interest, when they get a Social Security check or when they get a health insurance bill or whatever, this thing falls out. This could be called the silicon chip of the healthcare reform movement. This has been proposed to Congress. They turned their back on it. Here's why they turned their back on it. One, it doesn't cost the taxpayer anything. Two, it doesn't cost the health insurance company anything because the consumer group pays for the insert and there's no added postage. They don't use up all their postage. And three, it's voluntary for you to join or not. And four, it will create organized consumer power that will look over the shoulders regularly of members of Congress. And they don't like that. They don't want people back home organized to look over their shoulders, with very few exceptions. Now, this was proposed for the savings and loan bailout bill to organize customers of banks. They turned it down. That's when you know that this is a powerful idea. Because whatever you can say about your members of Congress, they understand power. Clinton has not adopted this. Bush has not adopted this. This is not in any bill in Congress. But this is what will lead to the intelligent organization of millions of consumers linked together, state by state, with full-time staff to reshape, recorrect, and continually monitor in a vigilant manner this massive segment of our economy that spells life and death, health and disease for so many people. And not just hospitals and doctors and drug companies, but tobacco companies and liquor companies and chemical companies and car companies. Fourth leading cause of death on the highway in this country. All the various forms of trauma and toxicity which can be subjected to an ounce of prevention to avoid a ton of possible cure. Not only in terms of disease, but in terms of waste dump cleanup. Think of how little it would have cost to avoid all the dumps in New Jersey compared to what you're now having to pay, not to clean it up if it can ever be cleaned up, just to contain it, to keep it from seeping more and more into the groundwater and throughout the ecology. Well, here's where we can roll up our sleeves. Out there's a table on your way out. First, there will be a sign-up sheet for people who want to organize in this area a health insurance reform citizen group, where you can connect with efforts by physicians and other citizen and health groups around the country for the coming battle in Congress in the next 2 to 3 years. The financial underpinnings of the health care system will collapse within 3 to 4 years. By the time we reach $1.47 trillion, it's going to be in very super serious crisis, not just in a macro sense, but the middle class will be revolting person by person. You already see it coming into the newspapers and television already. It's only the beginning. We should be ready for it. So we don't get another Band-Aid, we don't get another palliative legislation, that we get the kind of proposal that Consumer Reports just came out with. I just got this yesterday. Consumer Reports puts out the monthly magazine, you know. They just put this out. The health care crisis, affordable protection for all Americans. And this goes in, it's a very easy thing to read. You get more informed and more indignant with each passing page. And you can get volume copies by writing Consumer Report, 110 Truman Road, Yonkers, New York. 101 Truman Avenue, Yonkers, New York. And this shows what the waste is, what the crisis in health insurance is managed care the answer, long-term care insurance, and the reform proposals. Now, if you want to sign up and if you want to put a circle around your name, if you want to take a more active role, we will send the list to you who want to put a circle around your name, together with some information. Because every place in America, every community in America has got to have a group like this if we're going to be up to the challenge in the next few years. Just think of your children in terms of the kind of coverage they're going to have if we don't change the system. For non-inflation adjusted dollars, look at these figures. In 1950, $57 per capita cost of health care in the United States. In 1970, $360. In 1992, $3,300. Can't keep going. That's non-inflation adjusted. But even if you adjust for inflation, you're dealing with more than a tripling of the cost in 20 years. Now, I want to end on this point because I want to illustrate that all you've heard is just the tip of the iceberg. How many of you have heard of the drug Taxol? Taxol. How about AZT? Okay. Both of those were developed by the U.S. taxpayer. Your money sent to the Institutes of Health in Bethesda, Maryland, developed Taxol all the way from synthesizing the yew tree up in the northwest of our country. YEW, tree, was considered a weed tree for years, and it's probably the most promising anti-ovarian cancer and now anti-lung cancer drug about to be marketed. You, the taxpayer, took it all the way through government scientists that are paid by you, all the way to the clinical studies. And now the Bush administration has signed a monopoly patent agreement with Bristol Myers Squibb to give the whole rights to that drug company. They will then charge you whatever they want. It'll be the most expensive anti-cancer drug ever, according to a spokesman for Bristol Myers. They paid not a cent to develop it. They're going to market it, and it's going to be a very expensive drug. You, the taxpayer, get no royalties on the sales. They can charge whatever they want to you as a patient, and if you can't pay, you go on Medicaid, and you, the taxpayer, will pay on the other end. AZT is the same thing. Developed in Bethesda, Maryland, given to a British company, Burroughs Wellcome, under a monopoly patent. They started charging $10,000 a year per patient. It's down to about 6 or 5. A third of the patients can't afford it. Medicaid pays it. You paid to develop it. You got nothing from the enormous profits. You did not control the price to the patient. And because the price was so high, you paid through Medicaid. That's called deregulation government. Giveaway government. Giving away your taxpayer assets. This is an example of a problem that will not be stopped unless there are organized consumer groups specializing in health issues with full-time staff. As consumers, we are grossly under-organized up against the organized power of bureaucracy and corporate interests. And as long as that imbalance occurs, you don't get much democracy and you don't get much accountability. And if we're going to work 2 months out of the year before the end of the decade, the average person will work 2 months out of the year just to pay the health bill. If we're going to go through the kinds of collapses of Blue Cross and the pre-existing condition and larger co-payments and more deductibles and more exclusions and more age-related rating, etc., then we've got to spend more time as citizens to organize and do something about it. The other sign-up sheets are for getting a free copy of our health letter, which is very interesting, and getting a copy of our magazine, The Multinational Monitor, which focuses on the activities of global corporations. I just want to end on this note, and that is that as a society, we become more complex, we're affected by more events beyond our control. Therefore, our citizen activity has got to increase, and our citizen knowledge has got to be more specialized. And we can't all be interested in every problem. But some of you are interested in health care, good. Spin-off groups interested in health care. Some are interested in education, some in tax reform, some in pollution control. even if 1% of citizens are organized in each one of these areas, wonders behold in terms of what can be accomplished. We have enough examples of how a few people working in community after community have achieved wonders because they took time out from their television, they took time out from their recreation, they took time out from their card games to put time in as active and informed and organized citizens, developing the strategies for success and accomplishment. And education above all, and especially in community colleges, should be education for citizenship. That's the most important role we'll ever play in our lives. It's more important than our job roles for the future of our country. We can keep the economy humming in our job roles, but it can go right over the brink financially, ecologically, or autocratically if we don't pay more attention to our duties as citizens. And in 2 weeks, we are issuing our textbook for civics in action democracy for community colleges and high school students to try to drive home the point we've been talking about for years, which is there has to be more courses in high schools and in colleges where students are given the opportunity to develop their citizen skills by studying real-life problems in their community, as well as books and lectures in their classroom, and connecting the two. So we learn about the history of citizen action, which we hardly ever read about in our history books in our country, and we actually practice it as part of course credit. And if it's not course credit, it can be something like the New Jersey Public Interest Group, New Jersey PIRG, which is in effect an extracurricular activity funded and run by students at Rutgers and some other colleges in New Jersey. The blessings of liberty and justice no longer come from on high with a few enlightened leaders. They increasingly have to come from a renewed appreciation that a real pathway to happiness, a formula for happiness, is being an effective, involved, and achieving citizen with your fellow citizens. It will reduce the number of trips to therapists and the number of prescriptions for Valium and a lot of household squabbles that come from a very, very narrow frame of reference. The happiest people in the world are people who stand tall, who are active citizens, who go after injustice, and who take time from their lives to build a better society for present and future generations. We've inherited some of that from people in the past, and that's why we're here. But we've got to give even more to people in the future. Thank you very much. Thank you. Thank you. By the way, for those students who are interested in what the student activities are around the country, I'm going to leave this in the library. It's called More Action for a Change, and it's the story of the public interest research groups like New Jersey PIRG. Can we have comments or questions or statements, whatever? Anybody wants to announce meetings to time and place, by all means? Yes? I'm sorry, I didn't hear the last sentence. I'm wondering. Yeah, the role of malpractice suits and lawyers in the Canadian system. First of all, I'm just saying the Canadian system is superior to ours. I'm not saying that it can't be made much better in terms of its universal coverage. No one goes without. In Canada, they have malpractice suits. They have malpractice lawyers. They don't have quite the discovery authority that our lawyers have, you know, to ferret out the evidence. And they don't have the size of verdicts that our lawyers have. They have more restrictions. So I would say in terms of the rights of victims of medical malpractice, there is less medical malpractice per capita in Canada because the system either prevents some of it or roots it out more readily through the data. And B, where there is malpractice, you can't get as adequate a recovery in Canada as you can here.
Did you say there was a cap on awards in the Canadian system? Was that what you were saying?
Yes, but the Canadian lawyers are now figuring a way around that. Just like their workers' comp limits and the lawyers sue the manufacturers of the power presses and so forth. That is an evolving area of the law now. Yes. There are caps in some states, too, in our country. For example, California. Yes. Yes. Joint Commission on Hospital Accreditation? Yes. There's a very good book just came out on it by a Wall Street Journal reporter that paid quite a bit of attention. Our experience is that they're too soft with the hospitals, that they don't follow up on what they know in terms of censure, in terms of corrective demands and deadlines. And they very often flag their visits. In fact, almost always flag their visits. And so some terrible hospitals that should be shut down continue operating. And they are described in this book. Yes. Yes, we've seen enough of those on the television magazine shows where doctors can be criminally convicted of something, sexual harassment or worse, in one state, or even lose their license in one state, and they go across the country and they start up again in another state. That is going to come to an end. There's now a central database. Computers have got to be good for something, right? I don't know exactly what the administrative apparatus is, except that the medical review licensing boards are connected. There's one in every state. It's a state agency. I'm not sure whether the medical associations are linked, that they could help in this too. So now I think where there is a felony conviction, it is increasingly more difficult for doctors just to go 1,000 miles away and open up in Illinois after they fled or after they left New York. But in the area of malpractice, the Department of Health and Human Services, based on Medicare and other records, is going to start within a year, I think, a database with data on malpractice experience of doctors all over the country. Now, they're not going to make that public to you or me yet, but they're going to have it. By the way, do you know the doctors have a database on patients who have filed malpractice cases? And so they go, a patient goes to a doctor hooks into the computer, says this person won a malpractice case or has one pending, and sorry. There are some lawsuits on that too. But eventually, you see, it's not a very difficult thing to do to put all these records in a computer database and have them online reachable by any doctor, or any regulator, or any medical association. It's just, do they wish to do it? And a lot of them just don't care to do it. Now, one argument the doctors give me is this. If we go after another doctor, the doctor is going to sue us for millions of dollars for libel. And some doctors have. But the answer to that is to make the complaint to the Medical Licensing Review Board under privilege and let the government agency take care of it. They should be privileged, like a doctor-patient privilege, a doctor reporting to the Medical Licensing Review Board privilege. So I don't give that argument much credibility. You know, they're afraid to be sued. Other ways to do it in a more proper fashion, too. Yes?
A lot of people. A large amount of Medicare dollars is spent there. The $30,000, $40,000 funeral of an older person gets sick, goes in the hospital, intensive care for a while, ends up dying there. This is all known beforehand, and yet heroic interventions are utilized. Some have suggested that we voluntarily set limits on the amount of care given, particularly in the latter stages of life. Many people don't accept that. How would you see that issue?
Well, did you all hear that? Yes. Well, that is a real difficult, very difficult ethical question. You know, you can say, well, here are the criteria for pulling the plug, and then when it's your mother or your father, well, it's a little different. One way is a living will, where people basically write a living will, and they say, they say to their relatives, if I'm ever in a terminal condition, I've lost consciousness, there's no hope, you can give the authority to suspend, you know, I hate to say it that way, but it's to pull the plug. Basically, they can just stop feeding you intravenously and achieve that goal, or they don't have to actively make the termination move, which is an important distinction for doctors, whether it's done passively or actively. And they can get in real trouble if they do it actively. More and more people are writing these living wills. They're appearing in little pamphlets, how to write a living will. It's not very difficult. The second approach is the Oregon approach. By its critics, it's called the triage approach. They basically say that beyond a certain age, you don't get a transplant, and for certain procedures, if you're beyond a certain age, you will not get Medicaid, Medicaid backup for it. And I probably, along with you, saw that publicity a few weeks ago when the U.S. government disapproved the Oregon plan and therefore kept it from going into effect on the grounds that it would violate the Americans for Disabilities Act, because it would discriminate against very disabled people, which we sometimes call terminal patients. I have another objection. To me, to have hospitals and doctors and drug companies and all these people deciding this is a good plan in Oregon without first making a systematic effort to root out the waste, the fraud, the abuse, the vast executive compensation schemes that have been given to these hospital executives and so on. And before doing that, they go and they say, we're going to decide with a limited budget, we're going to decide who's going to live and who's going to die. In other words, the providers who are milking the system aren't taking the first cut. It's someone who's on a bed that's taking the first cut. And that's not the way to operate. Even if you can ethically justify it, you can't fiscally justify it unless you start rooting out the $200–300 billion of the $800 billion. That's gross waste, fraud, abuse, etc. Yes. Yes. Oh, yes, okay.
I'm with an organization based in this county that has a rather unique opportunity to affect public policy. Its objective sounds similar to your own. I'd like to invite anyone who's here to contact our organization in order that we can deal with Trenton, suggest re-regulation to them, and carry out some of the objectives that we have to do that. It sounds very sympathetic to your own program.
What is the agency?
They're called the Local Advisory Board Number 1. We have opportunity to address health regulations in New Jersey. We're members of the State Health Planning Board. We have a direct line to the Commissioner of Health. It's a relatively new organization with a very progressive administration, and we are a not-for-profit organization that meets at 5 Emory Place. Our telephone number is 361-3390, and we'd like to have your participation.
Are those all over the state?
There are 6 such organizations. They cover every county in the state. Our organization covers Warren, Sussex, Morris, and Passaic counties. In fact, it was in
set up by state law?
set up by state law, but sponsored in part by this college.
Can you give the phone number again?
It's 361-3390.
And would you mind signing the sheet, putting a circle around, say local advisor, and I'll send you the list?
Well, my whole staff is here. You're going to get 6 signatures.
Yes, sir.
You lightly touched on the issue of drugs and addictions and so forth, and it used to be arguable whether that was a progressive maneuver to legalize drugs. However, candidates such as Rudolph Giuliani and Mario Cuomo have even taken it seriously, though it's morally frustrating. What has your conclusion been on the facts regarding the legalization or the restriction of drugs?
Well, before crack cocaine came, I would tell you, legalize, regulate, control its distribution by the state, so you can collect all the addicted people who come for it, treat them as patients instead of criminals, and try to get them rehabilitated. Crack cocaine changes the situation, because you want people coming up to a government counter and saying, let me have crack cocaine. I know what doesn't work, the present system. I'm not so sure what does work. We have the example in the Netherlands, we have the example in Britain to work on. Britain was methadone. Netherlands, I think, is even more expansive in terms of what they provide to state. But you have millions of people in this country who live in fear because of street crime, half of which in some cities is drug caused, drug crazed criminals, you know, and burglaries, homicides on the street, muggings, a lot of it due to the drugs, corruption of our legal system, sometimes bribery of low-level operatives, police, and as Dick Gregory used to say, if a 9-year-old knows where the drug dealers are, why don't the cops? Of course, now that was 15 years ago. Now you say the 9-year-old is a drug dealer. You know, it's getting younger and younger. So I think we know it doesn't work. So that means we've got to experiment. We got 50 states, and we should try it. The mayor of Baltimore, who's a Rhodes Scholar, has been very outspoken in the need to legalize and regulate drugs, to get rid of the so much of the crime in the street, crack cocaine, babies, et cetera, bring it under the healthcare system rather than the law enforcement system, which isn't up to it. We would have to have almost a police state. I mean, Red China might be able to control part of the drug trade. See, because they just cracked down house by house by house. They got rid of a lot of the opium trade in the late 1940s. House by house, drag them out. The civil liberties, are you kidding? You know, rehabilitate them, do this, you know, imprison them. We won't do this. We can't do this. We won't do it in this country. So it's either a health problem or a law enforcement problem. When it comes to addiction, there's no contest. It's got to be treated as a health problem. So we need to experiment. A lot of good ideas. A lot of good ideas. I mean, not all comprehensive, you know, here, there. We need to get over this idea that the Army, Air Force, and Marines are going to take care of the problem. Yes?
Such a dedicated and effective advocate for the American public, and for the past 25 years, and wish you continued success in that field.
Thank you.
My question is, what are your comments on dentistry, chiropractic, and plastic surgery, and those in those industries?
And 3 galaxies. Well, I mean, dentistry is now losing a lot of members in the ranks. You know, they're shrinking. Dental care has advanced. Now it's primarily dental gum care that's more and more focused, and dental cosmetic surgery is a growing area. They're looking for work, you know. Major dental schools have closed down. Georgetown, biggest one of the biggest ones, closed down. Not enough business for new dentists. Well, that's good. That's good sign. I mean, that's prevention, putting themselves out of business a little bit. But I mean, no point going into all the problems that dentists have, and right now, except just to point out that in their search for work, they're now moving into some fringe areas of dental cosmetics. And that gets into plastic surgery, which, you know, for people who are burned and scarred, is very, very important. But you know what it's going into now? It's going into complete contouring of the body for the thinness craze or the shapely craze or this and that, silicone breast gel implants, all the pain from that. And a lot of it is due to the fact that our standards of beauty are created, promoted, and commercialized by corporations instead of by ourselves. And therefore, when you see Vogue magazine, all the models and so on for these teenagers, that's their identity for beauty and body shape. And social sanctions come in if they don't aspire to it, they don't have a social life, they're looked askance on, they might not be able to get the kind of job, so they go for the plastic surgeons, plus the youth-oriented culture. So it's from our own hand. We've let Vogue and the cosmetic companies and plastic surgeons begin increasingly to whip us into a commercial definition of beauty and body size that we have no input on. No common sense can change it. It's like a whirlpool. And you've seen some of the results on TV with the whole silicone gel controversy. But apart from how safe, how unsafe, what bleeds, what leaks, what doesn't, think of what drove 80% of those implants was the feeling that women, to be accepted, etc., had to have these implants. It had nothing to do with cancer. 20% are cancer, mastectomies, and so on. 80% are commercialized aesthetics. And beauty is not supposed to hurt. It's not supposed to produce anguish. But when you allow commercialization of beauty, unilateral shaping by corporations of standards of beauty, which manipulate, reshape themselves from year to year, you produce enormous anxiety and concern from the teenagers to elderly people who are overly worried about brown spots on their hands, etc. So I could really go on with this one, believe me. The letters I get, I often wonder what Ann Landers must get. Youngsters about to commit suicide because their nose is a little crooked, their eyebrows, just crazy. Animals in some ways are so far ahead of us. Can you imagine a lioness thinking she's not pretty enough? I mean, skulking, going off, you know. Just, we have a lot to learn from animals. Just a quick story. I was once walking home with my dad from his restaurant when I was a kid, and my sister was walking with us, and we saw some boys taunting a dog. You know, not quite beating the dog, but you know how boys can beat our dogs. This dog is cowering and so on. And they were saying, dumb dog, stupid dog. My father turned to us and said, yeah, real stupid dog. Real stupid. Doesn't foul its own nest. Doesn't declare war. Real stupid. You ever see a dog defecate in a little pot and then turn around and eat from it? You ever see a dog with Gaines dog food? The dog first defecates and turns around and eats it. That's what we're doing in pollution. We do this to our water. We do it to our air. We contaminate our food. Dumb dog. Real stupid, aren't they? Animals, just so dumb, have such a low IQ. Couldn't pass a multiple choice test. Yes.
New Jersey has a significant problem attempting to provide for hospital care for indigent patients. How do you feel this could most appropriately be provided for?
Hospital care for indigent patients?
Correct.
Well, the single payer system. I mean, I'm not into Band-Aid, you know, readjustments or here or there. Health care in the United States should be a right of citizenship, universal coverage, and that's the end of it. Now, for the here and now next week, that doesn't sound like much of a proposal. So what do we do in the meantime? That's the real problem. What do we do in the meantime? And, you know, you have 4 nonprofit hospitals say they take these poor cases, poor people's cases. That's why they have to charge more for other paying cases, etc. Some hospitals refuse to take these cases on an emergency basis. In Texas, that occurred with some highly publicized deaths as the ambulance went from one hospital emergency driveway to another, desperately trying to find a hospital that would accept this poor person who didn't have a credit card. And after a few deaths, Texas passed a law making it illegal for a hospital to turn away an emergency patient for inability to pay. Yes.
How does the Canadian Medical Society approve of doctors getting their education from other countries like Mexico and other countries like that?
I mean, do they allow them to?
Yes.
Well, I think there is reciprocity between countries, not all countries, but certainly in our country, someone goes to Mexico, gets a medical degree, they come back and they practice. They have to pass the boards. And the same in Canada. They have to, no matter where they're trained abroad, unless it's really an atrocious training, you know, where there's no recognition.
Well, 2020 had a show about how the tests that they took practice in the United States after getting your education from another country outside, how easy they were to pass and how inappropriate they were for the doctors to practice in the United States after having such a poor education. I was just wondering.
Well, I wasn't aware that the medical boards were very easy. I didn't see that 60-minute. These are the board examinations that are conducted in the U.S.? Oh, you're saying the test isn't the same one as someone who goes through medical school here? Oh, I'm sorry, I'm not familiar with that. My impression, and I've talked to some young foreign doctors, they have to take the same test. Maybe some states have that double standard because they're so desperate for doctors who do the nitty-gritty work on weekends and in hospitals where they can't get enough doctors. So they use more and more foreign doctors. Yes.
Excuse me.
I couldn't hear you. You want to put the PA system next to you?
What do you think people should know about reasonable and customary rates for medical bills so they can get quality care and not get stuck for more of the bill than they thought they were going to pay?
How would they know what's reasonable? Well, what's reasonable is what is the going rate in the community, which doesn't tell you much because they all charge $7 for a big razor. That's what's reasonable.
Well, the insurance companies will pay what's reasonable and customary,
right.
But if you choose a more expensive doctor.
And too often, the insurance companies pay the prevailing rate. Now, some of them are getting tougher, and they're basically disqualifying some charges, telling the hospitals that they have to redraw their bill, and in fact, they won't pay for this. And they're getting tougher, but it's amazing how much of a drop in the bucket it is. I still see the same outrageous bills coming in, and you still see the same ads by insurance companies telling us they're cracking down, they're cost containing. The people who are doing the real cost containing are these company-sponsored plans, and sometimes they are so severe that managed care moves into the area of illegitimately rationing care. You got to look at it on that side as well. But there are three ways to see. You want to check your bill. One is have your insurer. That may get you somewhere. Check over reasonable charges. The second is send it to the insurance commissioner of the state and have their health insurance unit check it over. And the third is to send it to the relevant unit in Human and Health Services in Washington. The fourth is send it to your attorney. There are now more and more patients who are just refusing to pay. There was a woman who was in for 2 days. She was charged $18,000 for a whole variety of, all kinds of things, and she refused to pay. Took it to attorney, and they cut it by 2/3. So we're seeing more of that coming. And now there's a major class action in Florida, which won against several hospitals, cutting back all kinds of overcharges. And that is now going to spread all over the country because it's interesting to lawyers. The lawyers now see a way they can make money out of it. Another market is created. Yes. Absolutely. One, you'd save about $100 billion a year in administrative costs. Some say 130. Two, because you had a single payor, there'd be very minimal incentive for over-operating, over-treatment, over-diagnosis, over-prescribing. And third, with a single payer, you control doctor, hospital, and drug company prices. The drug company prices are controlled on a chart, and in Canada, they're much cheaper than they are in the U.S., sold by the same drug company, often stationed in New Jersey. And for doctors and hospitals, they're controlled because the hospital is given a budget, and they work within the annual budget to provide health care. So, again, this study here has anywhere between $200 to $300 billion knocked out of the $800 billion, and that's more than enough to cover the 40 million who are not covered at all in our country. So you add all of that up together, and you will not only have a more efficient system, you have one that has data that moves toward preventive care. For example, in this country, you can get health insurance. You say, I want to get an eye exam or I want to get a physical exam. They don't cover it. I mean, only a few years ago, the Blues were bragging. Some of them, they would pay for your physical exam. So in Canada, you go in for preventive checkups, it's all covered. Now, some people say Canadians overuse the system, and naturally they do, so they're being charged a little bit like $5, $10, $15 for a doctor visit, just to cool off the people who, instead of watching a soap opera on TV, go visit their doctor. But you can see that there's more early detection. There are people in this country, especially minority people, who die because they do not have health insurance, literally die. The studies have shown tremendous disparities in fatalities between people who have health insurance and people who don't. They don't go in for checkups. They don't go in for diagnosis. It's an alien culture to them. They've never been there. They don't know what to expect. They live in isolation from the healthcare system, along with their children. So, by the way, this is really something, as I said, I just got this yesterday. I'm very impressed by the clarity of it and how well documented it is. And again, if you want to get copies, and they have bulk copies, it's Consumer Reports, 101 Truman Avenue. That shouldn't be hard to remember since Clinton and Bush both say they're like Truman. Yonkers, New York. If you want the zip, it's 10703. You don't need it. And just say, copy of the health care crisis and affordable protection for all Americans. I think for bulk orders, it's down to $250. You get bulk orders, they'll charge us $250 a piece for it. Otherwise, it's $4.95. Yes. Yes.
Actually, Mr. Nader, I agree with a great deal of what you said. I think that there's a great deal of waste and I suppose some corruption that's responsible for the excessive expenditures. I get the impression, however, and correct me if I'm wrong, that your principal means of redress would be to, besides getting the people more involved and more aware of what they are spending on and focusing, of course, on preventive care and whatnot, I gather that your main means of redress would be through government regulation. And one concern that I have that immediately comes to mind there is that the simple truth of the matter is that, in my humble opinion, there's a great deal of waste and corruption in the government overall. And in fact, I can think of, I'll very briefly go into an example. I can think of a gentleman I know who worked with an electronic device of some sort that I'm not very familiar with for roughly 3 weeks. And as a result of that, he developed cataracts. And he had an operation performed on the eye. It was a bad operation, bungled. And when he approached OSHA, hoping to get the company that he worked for to in some manner help him. OSHA informed him that there was nothing wrong with the device, and his cataracts had nothing to do with it. I'm not a physician. I don't know all the facts, but I have to wonder, and I suspect that to implement your policies, your program, which I think are commendable overall in general, I think that we need even more, and it has to be done on a general basis. The whole government overall has to be refined. Thank you.
You're quite right. That's why I put such an emphasis. I mean, the one thing the government can do in terms of being a single payer, it's done at the provincial level in Canada. It could be done at the state level. In terms of payer, that doesn't mean they do everything. You still have your free choice. There's still competition, doctors, hospitals, but there's a rigor that's involved. There's a consumer presence that's organized. And in the final analysis, it's organized consumers who are the best safeguards of the healthcare system, both in terms of their own personal healthcare and in terms of the institutional healthcare. In our country now, we have the most perverse incentives. There is an incentive to waste. You make more money. There's an incentive to operate when you shouldn't operate. You make more money. And we got to reverse those incentives. We have precisely the wrong economic incentives operating. Yes?
For the presidency. Would you consider it in the future, and why did you decide not to pursue it in this election?
Well, I never did run. What I did was I went up to New Hampshire and asked people to write my name in for president, even though every day I would say, I am not running for president, but I want you to write my name in as a none of the above protest and in support of the Concord Principles, which are reforms which we have worked on to upgrade our democracy, for want of a better word, to develop a new citizen toolbox for the democracy of the 21st century, because many of our tools are 19th and 18th century. They're not up to par with modern bureaucracies and corporate power. And we called these reforms the Concord Principles. And I have a copy for any of you who want them. I have a few copies here. And so we went all over the state. We had 3-4 hour sessions with people in auditoriums. We were, until the last 2-3 weeks, outdrawing the candidates by 3-4 to 1, because people wanted to grapple with reality. They didn't want someone to say, my fellow Americans, I'm running to be your president. Our country's in trouble. You know it, and I know it. And I have a plan to turn America around so that everybody who wants a job can have a job, so everybody who needs health insurance will have health insurance, so we can hold up our head high in the world among the community of nations once again. Let me have your vote. When I go to Washington, when you place me in the White House, I will never, ever forget you. God bless you. Listen, we had real good discussions. The interesting thing is that, by the way, to ask for a write-in vote for a candidate who keeps telling you he's not running and he's missed all the deadlines in a machine vote state, by and large, not rural areas, but city, New Hampshire, is like asking someone to run a 100-yard dash with leg irons. But I got about 2% of the vote. I got almost as many votes as Cuomo. But what was interesting is this. I got exactly the same percentage of Republican and Democrat votes as turned out in the election. In other words, I got 52% Republican, 48% Democrat, which shows that people are interested in basic rebuilding of democratic power so they can regain control over their government and their future, even though they may disagree on certain policy issues vigorously. It's like I may disagree with you on health care policy, but we both agree that we should have the right for free speech. And what the Concord Principles do is give people those basic levers of information, transmission of information, mobilization for action as voter, taxpayer, worker, consumer, and shareholder. Those are the 5 key roles that we need to upgrade the citizen toolbox for. So that's the story. I also ran in Massachusetts, by the way. I got 33,000 votes in Massachusetts, never missing a day saying I'm not running for president. See, I was trying to get people to want to support a binding none of the above option on ballots in the future, so that if you didn't like Tweedledum Tweedledee candidate, you were left with an option other than staying home and being accused of not voting and apathetic. You could go down the polls and vote for none of the above. If none of the above won more votes than the other candidates, it cancels the election, sends the candidates packing, and orders a new election. Now, just the fact that you've got that kind of potential lever over the candidates is going to make them spread out more, not be so much alike. Otherwise, they're canceled. No more humiliating defeat than to have a politician lose to none of the above. Yes. Yes. The reason why Medicare is horrendous, for 2 reasons. One, all the Medigap policies and trying to figure out supplementals. And 2, all the internal, this no, this yes, do they take assignment, are they charging you more than Medicare, you make up the difference, 80%, 20%. In Canada, you just have the card. You just present the card, it's all over. That the government agency pays a budget to hospitals, etc., and that's it. The number of bills and cross collections and you trying to figure out who to pay and when and what you have to pay and what the insurer pays, 0. So it isn't the government per se.